It's on there now. I see the record button.
Great, we're recording and we are broadcasting.
We ready?
We are ready.
All right, good morning. My name is John Packham. I'd like to call this meeting of the Patient Protection Commission to order with my virtual gavel and have Ms. Mayville call order, please. Call roll.
Thank you, Mr. Chairman, and good morning. I will start with our voting commissioners. Chair Packham.
Here.
Dr. Barron.
Here.
Teresa Bohannon.
Here.
Bobette Bond.
Here.
Jessica Flood. Jessica Flood. Can you hear me, Jessica?
Yes, I can hear you. I'm on mute.
Okay. Okay. Thank you.
Thanks.
Flo Khan.
Commissioner Khan, just to note, indicated that she will be late, Mr. Chairman.
Okay. Dr. Khan? Is Dr. Khan here? Okay. Yarleni Roa Dugan? Is Yarleni here? Sean Shaner?
Hold on, Yarleni is here. Let me just ask her to unmute.
Oh, okay.
Bear with me.
Okay.
Okay, Yarleni should be on.
Yarleni Roa Dugan?
Here.
Okay.
Okay.
Sean Shaner?
Here.
Dr. Slonim? Mason Van Howling?
Present. Good morning, everyone.
Okay, now moving on to our non-voting commission members. Insurance Commissioner Barbara Richardson.
Morning.
Jamie Sawyer on behalf of the Silver State Insurance Exchange.
Good morning.
Director Richard Whitley.
Here.
And then moving on to our commission staff, Executive Director Chulhajian
Here.
and Chief Deputy Attorney General Gregory Ott.
So, Mr. Chairman, our DAG indicated he will be attending. He is in another meeting momentarily, but should be joining us within 10-15 minutes as well.
Okay.
Okay, Mr. Chairman, that concludes our roll call. And if everyone comes in that said they would be late, we will have a quorum.
Okay. So please, just for the record, Ms. Mayville, Dr. Slonim absent but excused, and
Okay.
Flo Khan present when she joins us in 10 or 15 minutes.
Yes, sir.
All right. It's good to see everyone, even though it's virtually, and appreciate everyone's ability to ramp up the commission again. I checked my calendar last night, and since UNR sent everyone home on March 18th, this makes my 298th Zoom meeting, and I'm really tired of Zoom meetings, but we probably have 298 more until we meet again in person, and I look forward to that, but am quite jazzed that we are able to catch up again. This will be the first time that I have done a Zoom meeting with close attention to open meeting requirements and law and so forth. and appreciate the assistance of Sarah and Leslie in making this happen today. But there will be hiccups from time to time, and I ask you and those watching on the live stream to bear with us as we figure this out as we go. Next agenda item is public comment. I'm going to ask Sarah to coordinate this and ask those submitting public comment to limit their comments to 3 minutes and limit your comments to items on our agenda. Even though we have some pretty broad categories, I ask you to do that. I also like to remind you that you can submit public comment online at our website that I think most of you have visited or acquainted yourself with. So with no further ado, Sarah, I will ask you to help get the ball rolling on public comment.
Sure. Thank you, Mr. Chairman. For those of you listening or viewing live on the stream, Mr. Chairman's correct. You can submit public testimony either prior to this meeting, during this meeting, or after. Our preference is for you to send in any testimony via email at ppcinfo@gov.nv.gov. First, what I will do is we had several virtual attendees. We have 38 currently online with us. 4 of them have indicated that they wish to speak publicly. But before I start with our virtual attendees, let me pause and ask Leslie if we have anyone who has submitted virtual test or submitted any written testimony, and if so, please read that into the record.
So far, we have not received any virtual or anything via email. We have a few more people that have just attended. So I'm trying to write those down at the same time as I'm doing this. So I'm checking back and forth.
Okay, great. So I'm going to go back to our virtual attendees. Again, we have 38, 39 now on the line. If anyone wishes to speak during public testimony, please raise your hand. I will be able to see you raising your hand. For those who have indicated that they would like to speak during public testimony, again, we have 4 that registered in advance of this meeting. I will ask you to, I will allow you to talk, and then you will be given the allotted 3 minutes that Mr. Chairman had indicated when he opened up this public comment. I'm going to start with Miss Vivian Leal. So bear with me. Let me go ahead and enter her into the meeting. Miss Leal, you should.
Thank you. This is Vivian Leal, and I mission to keep in mind the tens of thousands of immunocompromised patients as you look ahead to see what we will do regarding COVID. Just like everyone has suddenly felt at high risk and vulnerable to this virus, the many of us who are immunocompromised live this way, and we will be living this way for a much longer time until there are treatments and vaccines. Even should we get COVID and be able to survive it, the very conditions that we are being immunosuppressed or immunocompromised for will then attack our bodies, whether it's organ rejection or MS relapses. And so we will need some of the concessions that have been made temporarily for everyone during COVID to continue so that we don't have to seek in-person care unnecessarily, so that our pre-authorizations and approvals are granted quickly and we don't drop off our care system as some of these emergency measures come offline. So I'm just highlighting to you this community that will have to continue living the way that everyone is already tired of. We're in it until there's real treatment or cure. And so I encourage you to keep us in mind and not forget us as you address the larger population. Thank you.
Thank you for your comments. Sarah, before we turn to the next public comment, I'd like to note for the record, Dr. Khan's joined us.
Great. Okay, now moving on, looks like the next person is Miss Amy Shogren.
Hi, this is Amy. Hi, Chairman Packham, members of the commission and staff. Amy Shogren, I'm the Director of Communications with the Nevada Hospital Association. Nevada hospitals responded without hesitation to treat patients in the COVID-19 pandemic. Our data was and continues to be instrumental in making critical public health decisions about the safety and well-being of those in our state. We're eager to hear today's update being provided by the commission, the presentation being provided by the state, and we look forward to articulating the hospital's response to COVID-19 to this commission at a future meeting. Thank you.
Okay.
Thank you.
All right, thank you. And then we have Dr. Joel Bentz will be the next one that we will unmute. So let me just find him. Okay. Dr. Bentz?
Yes, I'm here. Can you hear me?
Great. Yes, I can hear you.
Thank you, Sarah. Yes, thank you. My comments are about insurance network adequacy, and I'd like to provide a statement for the committee. Chairman Packham and members of the committee, I thank you for the opportunity to provide public comment. To summarize, my name is Joel Bentz. I'm a board certified pathologist and licensed to practice medicine in the state of Nevada. As some of you may know, my pathology group, which is called Laboratory Medicine Consultants, or LMC, we've served the Las Vegas community for almost 50 years now. We currently employ 28 board certified and subspecialty trained pathologists, and we're probably the largest group of pathologists in the state of Nevada. We provide 24/7 around the clock coverage at almost every hospital in Las Vegas, as many of you may know. That includes University Medical Center, all of the HCA hospitals, and all 6 of the Valley Health System hospitals. Why do I appear? I appear before you today to request that as you develop your priorities, your work plan, and your future agenda items under item 7 and 8 of today's agenda, that you would include an evaluation of the insurance network adequacy in the state of Nevada. Why, in particular, we are concerned about the actions taken by Anthem Blue Cross Blue Shield in 2019, which will severely undermine the ability of all pathology practices in the state of Nevada to provide high quality care. And we think that this will inevitably lead to increased healthcare costs and decreased access for Anthem patients. So what happened was that Anthem made a decision to terminate our contract, and saying that they did not want to credential pathologists as physicians, and they instead reclassified us as technical providers. This was a unilateral decision, and it resulted in a reduction in reimbursement for our services of up to 70%, which is basically below what it costs us to provide service. And this is simply unsustainable, and it will force us to eliminate subspecialty pathology services in the state of Nevada. This all comes at a very critical time in our specialty, as there's a shortage of pathologists who are particularly necessary, again, as some of you know, in making cancer diagnoses. And this, this decision by Anthem will decrease quality of patient care in Nevada. It will discourage young physicians from pursuing a career in our specialty, and it will limit the pool of talented physicians that we can recruit to Nevada. This leaves us no choice now, but that we have to go out of network with Anthem, including at our hospitals, and this will result in higher healthcare costs and a decreased access to patients. We have previously presented before the Legislative Committee on Healthcare in 2019, and we humbly ask that for your committee's assistance on 3 aspects. protecting the professional status of pathologists as physicians. That's number one. Number two, help protect Nevada patients from surprise billing. And number three, that you help us ensure that pathologists will continue to want to practice in the state of Nevada. Thank you.
Thank you, Dr. Vince.
Okay, great. Now it looks like we have Mr. Bill Welch.
Thank you. This is Bill Welch with the Nevada Hospital Association. And I'll try not to be repetitive of Amy Sjogren's comments. However, I do appreciate the opportunity to speak to the commission. I want to acknowledge your agenda in that it was focused on the COVID-19 situation today, as well as the letter that the governor had sent to the commission of May 19th, 2020. And want to assure the commission that Nevada hospitals stand here prepared to work with you to address those requests that the governor had outlined in his letter of May 19th. We want to first acknowledge and thank the governor for his quick action, which we believe was significant in allowing Nevada to manage the COVID-19 so that we did not experience what other areas of the country had experienced. We believe that his quick action was the difference in making sure that we were able to bend the curve and keep the curve relatively manageable within the resources of Nevada's healthcare delivery system and other resources. Nevada hospitals, as one of the primary, not the only, but one of the primary safety net care providers, which function 24/7, here to meet the needs of the Nevada citizens, would appreciate the opportunity to speak to this committee of our experiences in responding to the COVID-19 situation. We believe that there were many challenges and that there continues to be challenges that we are learning from that would be helpful to this committee as they deliberate the request of the governor. Be assured the crisis, while we have managed the COVID-19 within our resources that we have available in the state, I want to emphasize the governor's stress that we need to continue the efforts to continue to deal with the social distancing, face mask, and do all the things that we can to continue to manage COVID-19. But I want to remind us all that COVID-19 is not going to be going away in the foreseeable future. And one of the things that helped us, in addition to the governor's quick action, is that we were coming off the normal flu season. As we move into the normal flu season this fall and continue to be responding to the COVID-19 situation, we need to be prepared to have our resources stressed and maximized. So we just would like to, again, thank everybody. We look forward to working with you, and we would appreciate the opportunity to come and make a formal presentation to you on the experiences of the hospital healthcare delivery system in responding to COVID-19. Thank you.
Thank you, Bill. Next, Sarah. Sarah, you're on mute.
Okay, so it looks like we had a couple more attendees join us since we opened, but it looks like no one else has raised their hand to speak. Let me just check in with Leslie. Leslie, did we receive any additional testimony via email?
Not yet.
Okay, great. Well, then that concludes our first public comment. I'll turn it back over to you, Mr. Chairman.
Okay, thank you. I'd like to move on to agenda item 3 and make just a couple of remarks by way of kind of our new focus and redirection of the commission. Most of you, and hopefully those who are viewing this on live stream, have read the letter from Governor Sisolak to commission members dated May 19th, 2020. And that letter contained a request for the commission, in keeping with our original charge as it was spelled out in Senate Bill 544, to focus on a set of issues that have been revealed through COVID-19 and the current crisis that we're attempting to crawl out of or recover from. In that letter, he asked us to prioritize our work, quote, to best serve Nevada at this time of state and national emergency, and requested that the commission, again, in keeping with our original charge, focus on 5 sets of issues that we're going to discuss in much greater detail later on in the agenda. But those include access and affordability of care, particularly those vulnerable populations in our state that have been disproportionately affected by COVID-19. He's also asked us to explore what innovative approaches to providing healthcare, improving access, and I think quite importantly, protecting health workers in this state need to be sustained, need to be supported, and so forth. And telehealth is the one that leaps out as an example of an element of healthcare that's changed considerably in 3 months, probably more in 3 months than the past decade. The governor's also asked us, thirdly, to devote attention to improving local, regional, and state public health and coordination. That is to say, let's not limit our focus downstream on the sickness care system, but also be thinking about what measures we can take through policy, regulation, and so forth to prevent individuals in our state from becoming sick or ill in the first place. That is to give greater attention in our deliberations to public health matters. Fourthly, he's asked us to devote attention to ways we might improve data collection and analysis for evidence-based policymaking and planning. You're going to hear a presentation from folks at HHS in the state. You heard earlier from Bill Welch at the Hospital Association. I think one of the very positive things to emerge in this is collaboration both from hospitals and other healthcare providers in the state in arming policymakers with data, and we've really upped our game as a state, and I know the governor would like for us to give some attention to what we can do to continue that, but also improve data for policymaking. And finally, and a topic near and dear to me, is he's asked us to think about health workforce development and what we can do as a state,
And I'm trying to get reconnected.
not only coming out of the current crisis, but being prepared for the next one with respect to workforce shortages. One of my great fears that was fortunately not realized is that a state that is beset with serious workforce shortages, what would we do if we had a sizable number of health workers test positive? I mean, one worker testing positive is too much, but I think that in preparation for the next time around, this commission and policymakers in general will need to give greater attention to health workforce development and addressing those shortages. So in conclusion, and so we can continue on with our agenda, there's a great quote from Donald Berwick. It was in a recent issue of the Journal of the American Medical Association. He said, quote, "Fate will not create the new normal, choices will." And I really take that kind of call to heart and hope that the choices we make as a commission can contribute to the resolution of the current crisis, as well as prepare the state for the next pandemic, which again will be something that we'll be mindful of the rest of our careers. So I'd like to turn next to agenda item 4, which is approval of the March 2, 2020 minutes, and would request a motion to approve.
This is Dr. Khan, so moved.
Do I have a second?
Word Barron, second.
Do I have any discussion? All right, all in favor, say aye.
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 Any opposed? Nay? All right. I believe that was unanimous. Next, I'd like to move on to agenda item 5, and that is an update from a couple of our state agencies concerning the status of COVID-19 in Nevada. Wanted to open our discussion and have Caleb Cage introduce himself, and maybe Caleb, if you don't mind, provide a brief description of the work you're undertaking. Want to let the commission and those viewing online today know that had several conversations with Caleb, and throughout the commission's work this summer and beyond, we'll be continuing to coordinate with him and his office and the efforts that he's begun undertaking in the area of public health preparedness and emergency management. Caleb?
Thank you very much, Chair Packham, and to the members of the Patient Protection Commission for the opportunity to speak here. I was having a little trouble with my microphone earlier, so I'll ask you if you can hear me before I ramble on.
We can hear
you.
Great. Perfect. Thank you very much. So I see on the agenda and appreciate the letter and the overview that you provided here, Dr. Packham. But I see on the agenda many of my colleagues who I've had the great pleasure of working with in this current crisis, the pandemic, from the Division of Public and Behavioral Health, are also on in this agenda item. So I'd like to keep my remarks relatively brief, introduce myself to some of you I've worked with in the past. As Dr. Packham said, my name is Caleb Cage. I am 3 weeks into a tour in Governor Sisolak's administration as the COVID-19 response director for the state. Proud to be here, happy to be here, encouraged by all of the great work that we're doing here in Nevada, especially as I get to work with Administrator Sharrock and Deputy Administrator Peak, who are also on this meeting and can provide updates later. As many of you know, I previously served as the Emergency Manager and Homeland Security Advisor for the state, where I got to work with Dr. Khan very closely, and previously before that, as the Director of Veteran Services, where I got to know Dr. Packham, and I'm looking forward to getting to know all of you even more. My role as the COVID-19 response director for the state is to basically oversee response and recovery efforts from the governor's office, which means coordinating the real work that's being done through the Division of Emergency Management as they support the logistics effort. Dr. Pandori at the Public Health Lab, contact tracing, which is overseen by DHHS and particularly DPBH, where I get to work with Julia Peak on a daily basis and more often than she would prefer, because I'm always putting more tasks and more work in her in her lap as we continue through this. But we basically work to make sure that the system works as a system, that we have the logistics, that everything is coordinated through all 3 lines of effort for that process. I'd like to build upon what Dr. Packham said previously with his introductory remarks about the letter that was provided, that was sent to this commission by the governor about a special role that you have regarding those 5 lines of effort or 5 mission areas for your recommendations: access and affordability of care, innovative approaches, improving local, state, and regional health systems, data, and health workforce. Those all very much align with our overall response efforts, and specifically with Governor Sisolak's response and recovery plan for the state of Nevada to COVID-19. The plan I'm referring to is Nevada United, a roadmap for recovery. I'd like to point out one of the 5 goals listed early on in that plan that states that it is our goal to take this, to turn our unprecedented challenge to governance, public health,
Caleb,
and economic development. Yes.
I'm so sorry, but I think that there was a slight delay. If you don't mind going back to your first bullet point, it just because you cut out for about 5 seconds.
Oh, my apologies. So I'll just take it back a little bit. So the 5 bullet points that Dr. Packham referred to earlier, providing healthcare, improving local, regional, and state healthcare systems, data collection, and health workforce development. Those all align very much with Governor Sisolak's Nevada United, a roadmap to recovery. And the 5th goal in that plan is to turn our unprecedented challenges into a rare opportunity to transform Nevada's approach to governance, public health, education, and economic development. All of those can be and are covered within the 5 points that are in the letter directing your efforts over the next few months. They align directly with what we're doing. And I'll conclude by saying we, within the governor's office and within all the partnerships represented here in the state of Nevada, are very eager to work with you, to learn from you, to hear your recommendations, and to help pursue in the legislative process, the policy development process, and implementation as we move forward. So thank you for the opportunity to present briefly here, and I look forward to working with you through.
Thank you, Caleb. All right. I'd like to next turn to Kyra Morgan, who is our state's chief biostatistician with DBPH, and a couple of folks that are joining her there. Give Sarah a second to pull up her slide deck.
Mr. Chairman, while she is doing this, this is Dr. Khan. Caleb, a quick question. While we are on Homeland Security, did we not have a session on the medical preparedness for bioterrorism or otherwise data available?
Yes, Dr. Khan, this is Caleb Cage for the record. Back in my previous role, we focused on, and you were a major part of our effort to reframe emergency management from a risk-based approach to a risk plus resilience-based approach. And that was, that included recommendations on data preparedness for public health crises or emergencies and disasters that dealt with public health. I'd be happy to find to provide that information on the bill drafts that went through the last session about information sharing and if those would be helpful in any way to provide updates on those, how we saw them impact this. I'd be happy as well. So,
yeah, that would be helpful. Appreciate it.
All right, Kyra.
Okay, thank you. Again, this is Kyra Morgan. I'm the state biostatistician for the Department of Health and Human Services.
To provide that information on
Can you hear me? I'm sorry, I hear some feedback.
Yep, I can hear you.
Okay, sorry about that. I'm just going to give a quick update on the status of COVID-19 in Nevada. And I apologize, Sarah has control of my slides, so I'll be telling her to move along to the next slide throughout the presentation. So next slide.
Bear with me. There you go.
So this is the goal of my presentation is to give a general update on COVID and then also to respond to some specific questions that the commission has had where those data are available. This slide shows our state's data dashboard for COVID. You can find that at nvhealthresponse.nv.gov. And just to note, this PowerPoint, I turned it in, I think at the end of last week, and these numbers are changing pretty quickly and evolving pretty quickly. So I'm actually going to give verbal updates with the newest numbers. And so the numbers that I'll be saying verbally are not match the slides. I also do just want to give kind of a shout out to my team. This dashboard is live. And so any of the numbers that I talk about today, you can reference independently to track COVID on your own. And we did, as a state, receive a really good feedback from a national organization called COVID Tracker, which compares all of the states and the availability of data that they present and the transparency of that data. And Nevada is one of 12 states that has an A+ grade. So please utilize the dashboard that's publicly available. Again, it's at nvhealth.nv.gov. So really quick, as of this morning, we had 157 PCR tests performed. So quite a big jump from the number you see on the slide. I think we're averaging about 5,000 tests performed a day in Nevada. And we've tested over 183,000 unique Nevadans to date. So far, we have 10,030 confirmed cases. That's a pretty significant increase from what you see on the slide. And we are averaging, I think, about 170 new cases per day. Our death numbers are up to 444 this morning. And those are coming in at about 3 new deaths to COVID per day. So if you move it to the next slide, we do have data available publicly to look at the burden of COVID at a county level. This is just a screenshot, again, from our public-facing dashboard. We now have case rates per 100,000, total cases, tests, and deaths, as well as death rates per 100,000 available at a county level. Clark County still has the most confirmed cases and deaths, followed by Washoe County. That's obviously not surprising based on population density in those areas. However, Humboldt County actually has our highest rate per 100,000 population, followed by Lander County, Washoe County, and then Clark County. And again, there are details on your screen, but those are a couple days old. So I would refer you to the dashboard for more updated numbers, or if you have specific questions, I could give an update on any specific county later on. The next slide gives a little bit of an update around new case growth. You'll see some pretty significant changes between what I tell you verbally and what's represented on the screen. At the end of last week, we were averaging about 126 new cases a day. This morning, we averaged 171 new cases a day for the last 7 days. That represents a growth rate of 1.8% rather than the 1.5% that you see on your screen. Deaths have been holding steady, again, still at about 3 new deaths happening a day to COVID, and that's a growth rate of less than 1%. The next slide goes into some of the measures that we've been monitoring regularly and that the governor has communicated as measures that are being used to kind of look at where we stand in relation to the phased reopening that started at the beginning of May. This is specifically a viral test, a PCR test, who are testing positive. Our test positivity rate was following a downward trend since about April 25th. Today is the first day that we've seen just a slight increase in our test positivity rate. It's at 5.5% right now. If you look at that trend, though, you could see that we reached a peak of 12.2% on our highest day, which was April 24th. So we're still much better than we were about a month and a half ago. Looking at confirmed hospitalizations, as Bill Welsh and others mentioned at the beginning of the call, as another key measure, we get these data from the Nevada Hospital Association. Confirmed hospitalizations followed a downward trend since about April 21st until about 4 days ago. And since then, we've had 4 consecutive increases in COVID hospitalizations. Again, we're still much lower than we were earlier on in the end of April and the beginning of May, but we have seen some very minor increases in the last 4 days. This morning, we had 199 confirmed COVID cases in our hospitals in Nevada and an additional 151 suspected COVID cases. The next slide gives some more information around the demographics of the people in Nevada who are testing positive and subsequently dying of COVID-19. So you'll see I've put some comparison measures on the screen here. You can look at age, sex, and race ethnicity by Nevada's population compared to our confirmed COVID cases and then our confirmed COVID deaths. And then I've just highlighted some of the significant populations where we see disparities. We've noticed that our Hispanic residents are testing positive disproportionately. So they're testing positive at a much higher rate than other populations. We've noticed that our Black non-Hispanic Nevada residents are testing positive and also dying disproportionately. And then our Asian Nevada residents, our male Nevada residents, and our older Nevadans, 60 plus, are also dying disproportionately of COVID-19. And if I didn't go into a lot of detail here, but if you look at the slide, you could see what those exact proportions are compared to our distribution in Nevada's general population. The next slide was a response to an inquiry that we had specifically related to COVID-19. In our facility have fall, what type of facility they're in. The pie chart actually has not been updated, so I won't be updating that verbally, but the numbers here I'll go through and give you an update as of this morning. So we had 1,313 confirmed COVID cases associated with the facility this morning. That's 13% of our total cases. 758 of those cases are for residents and 555 are for staff. 1,145 cases are in long-term care facilities. That's 13% of our total cases. And then 124 COVID deaths have been associated with facilities, which is 28% of Nevada's total COVID deaths. 120 of those were were residents of a facility, and 4 of those were staff of a facility. The last bullet point here is should be 119, or 27% of total deaths have taken place in our long-term care facilities. And I do want to draw attention to that increase and make a note that originally on my slide, I was only counting skilled nursing facilities. So the jump from 92 to 119 is not only, it's not really comparable, because I realized that long-term facilities should be including both skilled nursing and assisted living in order to make it comparable to national numbers. I also think it's important to acknowledge here that while it seems like 27% of our deaths being taking place in a long-term care facility obviously is a significant figure, but when we compare that to national numbers in other states, most states are reporting somewhere in the range of 30 to 45% of their COVID-19 deaths taking place in one of their long-term care facilities. And so even though 27% is significant and obviously terrible for those folks that rely on those services taking place nationally, and in fact, Nevada has lower numbers than a lot of our peer states. The following slide was also a response to a specific request from the commission related to a different set of facility releases. And these aren't actually related to cases at all. This is looking at from the start of the pandemic in Nevada until the initial phase of closures or stay-at-home orders. So the time period from March 1st to March 12th, we were asked how many people were released from state prisons, group homes, and state juvenile justice facilities. And so this is a response to that question. You'll see here that there were 189 individuals released from state prisons during that time, 87 individuals released from foster care group homes, and 11 individuals released from state juvenile justice facilities. And then there is a breakout on this slide displaying the specific facilities that DHHS has oversight on, specifically the state juvenile justice facilities and foster care group homes where those children or adolescents were released from. And again, these numbers are not specific to COVID. These are just the number of individuals who came out of facilities during the beginning of the pandemic before closures were put in place. And so my last slide really is just a summary of what you've got, a ton of data just circulating around COVID-19. I want to make sure that I'm concise in the message here. So minority populations in Nevada and older adults are disproportionately affected by COVID-19. 13% of Nevada's COVID cases and 27% of our deaths are associated with long-term care, and that's compared to 11 and 30 to 45% nationally. There are fewer cases, hospitalizations, and deaths than what we predicted by many of the models early in the outbreak. This means that social distancing and restrictions worked. We are still continuing to monitor models around the future trajectory of COVID-19, and they continue to indicate a high likelihood that Nevada reached our peak in the number of newly diagnosed daily cases in the end of April and has since declined. That being said, we have seen slight increases in our daily new cases since around mid-May. A lot of that is due primarily to increased testing. And then also just an acknowledgement that a rise in cases is likely to occur as restrictions are lifted. As of this morning, I started to see some of this effect on COVID hospitalizations. As I mentioned, we've had our last 4 days had some consecutive increases in COVID confirmed hospitalizations. That's the first time we've seen 4 consecutive days since April of increases. And then we have seen for the first time this morning a very, very slight increase in the test positivity rate at 5.5%. So I think what's important to acknowledge at this point is that because of the closures and the swift action that the governor's office took, Nevada has been able to build the infrastructure required for healthcare and public health systems to be able to adequately respond by providing appropriate levels of care and also containing the spread of the virus through contact tracing, et cetera. And that's probably a good segue into our next presenter, but I'll take any questions if there are any.
Any commission members have questions for Kyra?
Chairman, I have a few questions. This is
Okay.
Teresa Bohannon for the record. Can we go back and talk about what is happening in Humboldt and Lander County? I mean, they're obviously disproportionate to the rest of the state, and I'm just concerned. You know, I don't know how many hospital beds they might have there and what might be causing a higher rate of positive cases there. Does the state have any insight into what is happening there?
This is Tyra Morgan for the record. Off the top of my head, I wasn't prepared to answer that question, but I could definitely follow up with a response. I'm sure that from looking at the numbers, we've obviously had some outbreaks in those communities, and because those populations are so small, sometimes a small outbreak can, you know, not to downplay that, can have a really big effect on the rates in those communities. So just for context, the number of cases in Humboldt, I believe is the 8. In Lander is 23 confirmed cases. So comparatively, you know, from a magnitude perspective, those numbers aren't terribly high, but again, it's a small population. So I'm pretty confident to attribute those to some specific outbreaks. I also do know, just in monitoring the numbers day over day, that I haven't seen recent spikes in those 2 counties. So that would lead me to believe that whatever had happened has been contained at this point.
Okay. And then back, if we could look at the slide of the facilities, in terms of like the test, like how many positives we had in the various facilities. Do you know what proportion of staff and residents were actually tested?
I don't
Is it
I don't want to misspeak, but I believe we've tested almost all of our,
Like 75%.
I think 75% of our facilities we've tested at this point.
The goal is to have them all tested.
And the goal is to have them all tested.
Okay. And then, in terms of the releases, the state run, the juvenile justice and the foster care, do you know what the proportion of those numbers are? Those are just kind of a raw baseline of here's who was released. Do you know what proportion that is in terms of how many people were in state run prisons to how many were actually released?
Oh, that I don't know. So for the prison data, we get that from Department of Corrections, and we only get the releases. So I don't know what the denominator is, but I can reach out and ask them to get that number.
And do you know what authority, what authority released from the various facilities? So like for juvenile justice, was that a district judge, or I mean, who was the authority in terms of those releases? And do we know, in addition to that, do we know how many people in state-run prisons were tested
Okay, I think Director Whitley has the answer to one of your questions.
Okay.
Related to the releases, I don't know. We've just pulled anyone released, but I
Okay.
can follow up on that as well.
Okay. Thanks, Karen.
Hi, for the record, Richard Whitley, Director of Health and Human Services. So one of the priorities the governor had was to test the entire Department of Corrections, both inmates and staff. And so in partnership with the State Public Health Lab, that's been occurring. So they're at, as of today, 4,989 tests have been performed on both staff and inmates with the goal to complete, they're going prison by prison. So far, the positivity is 5 inmates at High Desert Prison test positive, 8 employees at Lovelock Prison, and 1 inmate at Northern Nevada Correctional Center. So relatively low positivity among inmates. The inmates that were the staff in Lovelock, I'm told is attributed at this point to carpooling from staff that when we identified that last week, our chief medical officer and state epidemiologist put out a bulletin to sort of inform employees and employers that what would be viewed as a good thing, carpooling for the economics, could put people at risk in terms of exposure. So those are the numbers for corrections, and we can provide those as a summary, but the goal is just like with the nursing homes to test all residents or inmates in the case of corrections and staff, and then to routinely test the staff. So for skilled nursing facilities, working with the state lab, we're looking at testing weekly the staff in nursing homes.
Any other questions?
Other questions? Bobette, I think you're muted. There you go.
Yeah, I am muted. I'm talking to
We're
myself.
getting used to that.
Yes. Good morning. Bobette Bond for the record. I just had a question. I think it's really helpful to see the case rates. I think that's the most important thing by county. But I also think we can't really see what's happening with increased rates compared to testing very well. Do you have the data to be able to trend both testing and rate so that we, not rate, but cases, so that we can see? I mean, the assumption is that it's testing that's increasing the number of cases, but it would be good to actually see that together.
Yeah, so those data are all available publicly. On slide 3, you can see that these data were on as of June 6th. So
that's what I'm looking at.
But you could see the cases per 100,000 as well as the number of tests and the total cases and the deaths. And then if you actually go to maneuver to the dashboard through the NV Health Response website, you can see at a state level, not at the county level, but you can see at a state level each day. So how many tests are attributed to what day and how many cases are attributed to what day. So you can go and look, like on Monday, if there were this many cases, you can go see how many tests were done. And that's
Okay, that'll help. Thank you.
another reason that we look at the test. Does that answer your question?
Yes, it does. I have one more question just because Mason's here. Mason, you guys have been doing all this UMC testing. Can I ask you how many tests you've been able to do?
Yes, Bobette, good morning.
Morning.
So our capacity is 10,000 a day. We have not done 10,000, but we have the ability to do 10,000 tests a day. And as you know, we've got a community center partnered up with the National Guard and Caleb and the governor's task force and the state at the Thomas and Mack. We're doing about 1,000 to 1,200 there a day. We've also worked with all the resort partners, culinary. Thank you, Bobette, over at the convention center, and we're doing some of the resorts and other clients there. And then we're also just supporting Southern Nevada throughout some of the other hospitals, doctors' offices. But we have a capacity to do 10,000 a day, but we're averaging around 25 to 3,000 a day. And so as businesses look to retest, and Richard, Director Whitley, I would offer up any of those skilled nursing homes that need to be tested, or any other businesses, we have availability and we can coordinate with them to test as well.
And Kyra Morgan, for the record, we do have the number of tests performed broken out on our state dashboard
Okay.
month as well. Again, this was as of the 6th, and based on the numbers that were just referenced, you know, this is probably several thousand behind at this point, but we were reporting over 41,000 tests from UMC as of June 6th.
And if I did raise my hand, so Mr. Chair, is it okay to ask my question of the experts?
Absolutely.
Thank you, Chair Packman. The question is regards to antibodies, and what's the view from the state, the department, related to antibody testing. Our lab is up and running regarding our serological antibody testing here at UMC, but how does that play a role into as we progress throughout the year? I know I've heard 2% testing of our population per month for the next year, but how do you envision antibody testing? And just to let you know, we're up and running in that regards as well.
So this is Kyra Morgan for the record. I'll say something quick and I'll hand it over to Dr. Azam. So just as it relates to the data we're presenting here, I just want to make sure everyone understands that we're not including antibody testing results in these numbers. From an epidemiological perspective, it's important to differentiate a viral test from a serology test, and so we're not combining those into one measure. We have had discussions about providing on our public-facing dashboard the results of antibody testing, and we just haven't had just the workforce, the resources to be able to do that yet, but it's kind of on our list of things to provide publicly as that gets up and running. And then just from the statistical perspective, you know, the reason we are interested in antibody testing is because of this idea of herd immunity. And it's really important that communities, for example, Washoe County Health District is doing a really good randomized study for their antibody testing. And that's going to be good information for us to have, but it's also important for us to understand that the idea of herd immunity in this particular case for COVID-19 really requires a very high level of herd immunity because of the way that this virus is, it spreads like fairly quickly. And so that requires a high level of herd immunity. And, you know, my professional interpretation would be that through antibody testing, we're going to have a good gauge of that. However, we don't expect that we actually have that level of herd immunity in our communities for that to be able to actually serve as a way to control the spread of the virus. And I'll hand it over to Eisen.
Good morning, everybody. Eisen Azam, for the record, Chief Medical Officer for the Division of Public and Behavioral Health. As you know, that antibody testing is under emergency authorization use still by CDC. And it is specifically designed to identify the prevalence of antibodies in a community. And that could be done on academic level or research level, is not yet authorized to identify, as Kyra mentioned, herd immunity, and techniques that a person was infected, being symptomatic, have that the COVID-19. So if they have antibodies, this is all what we know from the test. There's no evidence as of now that if a person has antibodies, that is equals immunity. We hope that it does equal immunity, but it's unknown at this time. As you know, really, the virus emerged 6-7 months ago. So there is not enough time to know if the presence of antibodies equals that the person is immune. And certainly if that is the case, which we hope it is, We don't know if the person is immune for how long they will be immune. Are they going to be immune for a year, for 2 years, for 3 years? We know from previous coronavirus events like the SARS-1 in 2003 that the antibodies meant long-term immunity. And we know from the MERS that the antibodies presence equal to 3 or 4 years immunity so far. So we don't know. All what we know about the antibody testing or the serology testing, that it is able to identify the prevalence of antibodies or the people with antibodies in the community. And the studies were done in New York and in California, and they showed that around 15% of the population developed antibodies, and they validated some of these studies by testing serologically individuals which we know that they had the infection, which was demonstrated through PCR before. So 15%, as my colleague Kyra mentioned, it is a very low rate, even if antibodies presence equals immunity. It's very low rate of herd immunity, because we're looking for a practicable or a workable herd immunity for this virus specifically should be between 62 to 65% herd immunity. So even if the presence of antibody is equal to immunity, that is very low as of now. What I know really that our state lab has 4,000 Abbott serology tests, and they are evaluating the possibility of conducting a random sample in Nevada or random samples among the population. Still really it's not determined how they will do it, or they will evaluate the prevalence of antibodies among specific communities like healthcare providers or in correctional facilities. But as of now, serology testing is under research and academic domain. Thank you.
Thank you, Dr. Azam. I appreciate it. And certainly it's important for the convalescent plasma therapy too, that I know we've done many cases here in the state, but thank you for the answer.
Thank you.
Thank you.
This is Jessica Floyd. So I want to just take a little different stance on this in regards to the World Health Organization's recently talked about how there's going to be a rising mental health issue regarding COVID. And so I understand that that's just like associated with it, but I was wondering, as you guys provide more data and updates as we have these meetings, if that could be contemplated in the data that you're reporting, whether we're looking at like crisis calls for law enforcement. I mean, I know that data isn't collected in as timely a manner as some of these COVID results, but I just wanted to put that out there.
Kyra Morgan, for the record, that's definitely on our radar. As you know, Dr. Woodard is really active in guiding us and what we should look at related to that. One of, as you mentioned, the downside there is we don't have the real-time data. So we have pulled some preliminary numbers related specifically to like overdoses and suicides or deaths that are at home, things like that. But those numbers right now are very, very preliminary, but we do plan to release additional information as it's available.
Great, thank you.
This is Teresa Bohannon for the record again. I just want to confirm that the case count that you provided, Kyra, does not include anybody who would have visited the state and tested positive. And I believe Julia is going to provide us an additional presentation about contact tracing. So I'm curious how a state that relies heavily on tourism with a 20-to-1 number of tourists to residents, how, if at all, the state is prepared to trace the number of positive cases that come and say visit a casino in Las Vegas and then travel back to their home.
Kyra Morgan for the record. So for the first half of your question, you're correct that we do not include non-Nevada residents in our numbers. For folks that are maybe monitoring our dashboard on a daily basis, you will have noticed that we've had rare occasions where some of our rural counties account might go down by one. And that's the reason for that. Sometimes we have a case reported as a positive, and then we subsequently identify that that person is outside of our jurisdiction, and that count will actually get removed from the case count. In response to how we contact trace related to the tourism industry, I don't have a response to that. I'm not sure if Julia might have a response in her next presentation. No.
Chair, did you want me to go ahead and take that question now?
Yes, please, if you don't mind. I'm going to ask my fellow commissioners to mute their mics when they're not speaking as well. Thank you.
Sure. Julia Peak for the record. I can actually address a couple of Teresa's questions. And Teresa, good to see you. It's been many years. So related to this specific question, there are processes if we have people from other states come into Nevada and have an exposure, and it's through a system that's already been in place. It's called the Interstate Communication of Confidential Records, acronym ICCR. And so that information is reported up to the state, and then the state's ICCR clerk calls the ICCR clerk in another state, and we communicate that information across borders. Where it becomes an international issue or exposure, then CDC typically handles that, and so we could communicate with them if necessary. The other really interesting tool that Nevada is assessing right now are citizen-based apps, and there's also federal legislation looking at the ethics of this and the use of it as well. But these tools can allow citizens and visitors to download an app on their phone, and it collects information, totally voluntary. It collects information on where they were, and if it's used really widely, then they can get notified if somebody that was within their vicinity for the period of exposure had a positive COVID case, and then they can follow up with their appropriate health department. So for a city like Las Vegas that has a lot of tourism, that type of usage could be really valuable and help us in public health identify cases when you don't necessarily know who you're sitting next to or close to in that environment. I can address the Humboldt County question as well if you'd like that, Chair. Okay, so Teresa also asked what was happening in Humboldt County. I'll talk about it in my presentation, but we've really got a great network now of rural county health officers, and the county health officer reported just anecdotally that there was not great compliance with stay-at-home orders in these groups, and then also with isolation and quarantine. And unfortunately, that causes the virus to spread more quickly. And I think since then, they've done a really great job in partnership with State Epi to address that.
I don't know if you guys are waiting on me.
Or whatever you want. I can dive into my presentation, whatever you want, Chair. Just let me know.
Please. Thank you.
Okay, perfect. So I am going to talk about briefly contact tracing, really high level, because I also provided a plan to the group that kind of talks about this, not in a huge amount of depth, but helps people understand some of the strategies we're doing. I do want to just take a moment to thank all the epidemiologists and disease investigators and contact tracers who do this daily. Contact tracing is not something new to public health, and those of you who've been in public health know that we use this for sexually transmitted diseases, tuberculosis, and really any infectious disease. What is different is now that this conversation is in popular media. I happened to go on a hike the other day, and I heard some people I was passing talking about contact tracing, which has never happened to me in my public health career. So it's something that now is getting a lot of attention, but I assure you this is not something that's new to public health, and we've been doing it for a long time. The difference here is the ability to expose quickly and also the scope. And I'll give you just an idea of what that looks like for us as far as quantity. If we just looked at lab reports that would hit our system on a daily basis for COVID, and that's negatives and positives, but truly all lab cases, that quantity exceeds what we would see over the course of a year for most infectious diseases. So that just scope for our public health system is so much larger than we're used to. And funding now to do some really great things related to contact tracing. And I just want to highlight a couple. The first is actually just human beings, and it speaks to the workforce issues that you will cover as part of this commission conversation. we've had to create opportunities to hire disease investigators and contact tracers at a level that was unheard of in the past. What was recommended by national groups is that you have anywhere from 15 per 100 to 30 per 100,000 contact tracers able to address infectious disease. 30, 15 during normal infectious disease investigations. Nevada was not even near that. Right now we have about 100 paid contact tracers that are working on COVID, and that needs to increase to 400 to 1,000. We're looking at right now on average about 600 to 700 until we truly see what's going to happen. So that human piece, what we've done, we worked with a company called Deloitte, and we are actually right in the implementation stage now. They are hiring 250 individuals to help us do contact tracing in the state. I'm really happy to know that 95% of those contact tracers are Nevadans. So it's truly, again, Nevadans helping Nevadans through this third party. As well with Deloitte, we're using a product called Salesforce, and it's going to allow for digital contact tracing. One of the things I'll note later on is public health IT is not amazing. We don't have a whole lot of money in this area. So when I talk about both the scale and scope of what COVID has brought to us, it would cause our systems to crash in just trying to import that level of data. So we're having to Band-Aid and or pivot in real time to try to make sure we can, and something I'm of, and Dr. Packham can as well, is our relationship now with the Nevada system of higher education is phenomenal. So much so that the chancellor and presidents of all the schools have been supporting us in both curriculum as well as in contact tracers. And so we're looking at a proposal for them to house anywhere from 150 to 200 contact tracers. Again, Nevadans, could be students, could not be students, but Nevadans to support this effort based on NSHE's ability. These folks will be trained and also be able to have the support of faculty and staff at the university. So it's really a great opportunity to merge the academic public health with the operational public health. The other thing that we're working on is standardization. So different counties do different things. That's just the nature of how public health works in Nevada. But through COVID, we've seen that the necessity is there to standardize some of those things. And so we're in the process of doing that now through the implementation of the digital contact tracing solution. This also will allow a contact tracer in a certain county to be redirected to a different county if they're having a specific issue, because we have now standardized training and those kind of things. Again, the second piece is just the technology. And so the Salesforce platform will allow us to send out text to contacts and cases and just notify them that through HIPAA compliance that they need to call their local health department, or the health department will be calling them. Typically in contact tracing, we call, they may not answer, we call back, and we keep calling until we actually find the person that we're looking for. So this is a great opportunity for public health to see how that actually works. And if it's a practical solution, this could streamline our efforts across all infectious diseases going forward. So we are about ready to go live with that. And then, as I mentioned earlier, we're assessing if there are opportunities to use that citizen-based app and what that looks like. Again, for our tourism, that could be something that is promoted and highlighted as folks enter the hotel or casino, and then that would help public health immensely. So I'll stop on contact tracing for a minute and talk broadly now about public health. COVID has shown us the cracks in the public health system and shown us how we need to quickly try to fix those with a Band-Aid and what possible look like. And Director Cage mentioned that we are really looking at this as an opportunity. If there is any place for a silver lining in what's happened in our state and the world, it is to look at how we can improve public health. So I just want to highlight a few things, and then at future meetings, if you'd like more information, I can certainly come back other people. So in Nevada, we're a hybrid decentralized public health system. So in the two urban areas, they have independent health departments, and they work and function really well and independently. And then we also have counties who work together, like our Quad County region in the north, that have done a phenomenal job. In the rural counties, they're required to have a county board of health and a county health officer. And I'll tell you, when I first started calling the counties and the sheriffs who serve on that board to say, tell me about your county board of health, I did get several responses like, I have no idea what you're talking about. And so we quickly did communication on that and established their boards of health, which has been phenomenal. So they should have those functioning. They should also have a county health officer. And in some cases, we didn't have county health officers. And so we quickly were able to find out who that point of contact would be in each county. And they've really stepped up, doing such a phenomenal job locally. For those counties that don't fall within the district, they do fall under the chief medical officer at the Division of Public and Behavioral Health. So our EPI team does case investigation and contact tracing on behalf of the counties. I had great discussions again early on where counties did not even realize we were doing this within their jurisdiction and thought they had to stand this up from scratch. So just that communication of how it's a partnership. I do see great opportunity here to revisit conversations that we've had in the rural counties to establish a district health department that would allow the state not to be hybrid and to truly be a decentralized model where all of that is done locally and then the state is there to support. I know in the Elko region, they've had great success. We also have the opportunity to work with CDC, and they're going to be funding 8 positions actually within our state through their foundation. One of those positions that I hope to announce soon will be handling regional rural efforts. And one of the things that they'll be able to look at is the opportunity to establish districts. So huge opportunity, even though it was brought up in the midst of crisis. The other thing that I want to say is we've been assessing at the health districts and state health department the opportunity to establish academic public health departments. And that really is a contractual marriage between the two entities where we host interns on a regular basis. We have the opportunity to teach on campus, and you merge, again, academic with practical workforce issues for the state. I think that's well under its way with what we've done in contact tracing. So I'm not going to pass on that, and hopefully we can establish those formal relationships. As I mentioned earlier, the opportunity to standardize. We use different systems in different areas of the state, and that has complicated Kairos' ability to collect data and push data out to the public. So we're going to work through those things. And then the modernization of IT. It's really hard for public health to get money for public health direct service, even harder for public health to get money for IT and data and those kind of things. Though absolutely the foundation of what we do, that's been an issue. But as an opportunity, we've received a great deal of money from the CDC through the EPI and lab capacity grants. And part of that is modernization and posting of data and ensuring that it's accurate. So we, again, will not pass on that opportunity. Any improvements that we make through that funding will help our public health system much more broadly. So with that, that concludes my presentation. Happy to take questions, and hopefully I have answers for you.
Questions from commissioners?
This is Dr. Khan. So a quick question on this contact tracing. Obviously, it's a major undertaking. Do we have any goal or targets to accomplish over the next few weeks, months, years?
Dr. Khan, excellent question. Julia Peak again. So some benchmarks. So we are trying to shoot for at least 600 contact tracers that are trained and ready to help should we need it. The 2 benchmarks that we've set for ourselves as a standard is every case is investigated or communicated to, again, they might not answer within 24 hours of us receiving their lab report, and then we continue to contact them. Include that case interview. Any of the contacts identified by the case are also communicated to within 24 hours of that case. With the identification of cases, I'll just add this, it's a really important benchmark. Through that EPI and lab capacity grant, they've set the minimum goal of at least 2% of your population is tested each month through December. So that's another really important benchmark that we're tracking, I apologize, in our ELC grant.
Thank you.
Thank you.
Other questions? Julie, I had one question for you. I'm curious, if some of that training is for contact tracers who can speak Spanish, or even Mandarin Chinese and so forth for visitors, particularly out-of-state visitors, but other residents of the state.
Yeah, outstanding question, Julia Peak again. So a couple things we've put in place to address that. Some counties have specifically recruited bilingual contact tracers and case investigation support staff. With the Deloitte staffing that we hired, that's part of the contract. So they not only are recruiting for staff that can be bilingual, but also there's a language line that we can bring in simultaneously to the conversation with the case or contact, so that we address.
Other questions?
Mr. Chairman, this is Teresa Bohannon for the record. I don't really have a question. I just want to, I want to say that I think that the state has done a phenomenal job. You know, hats off to Kyra and Julia and Richard and Dr. Azam and everybody, the whole team who has made data regularly available during this pandemic. Obviously, we are flying blind if we don't have the data. And so I think that they have done a really good job. And I just want to harken back to the very first meeting. I made a statement that we underfund public health in the state. We have historically underfunded public health. We have issues with racism and disparities in our system. I think that the data presentation here today laid that bare. And I think that we as a commission need to address this, because the other components of public health don't go away because there's a pandemic. We still have high rates of smoking. We still have, you know, high rates of women who don't access prenatal care. I would be frightened to see what deaths due to other comorbidities were like during this pandemic, because people weren't able to go see their physicians on a regular basis. So I just kind of want to make that statement again, thanks to the state and all the local health authorities, and of course, all the hospitals and doctors and everybody who just did what they had to do during this pandemic. But I do think it lays bare the real uphill battle that we have here in the state.
Hey, Jessica, you're muted, Jessica. Jessica, if you were trying to speak, I believe you're muted. There you go.
Sorry, I was talking on the phone.
Oh, that's a
Sorry about that.
multitasking that never happens on Zoom calls. All right, well, Julia, when we settle on future meeting dates, I will have you put those in your calendar, because we will definitely be asking you back. One of the conversations that I've had recently with Dr. Pandori at the Health Lab is how we pivot from data that's largely being collected for diagnostic purposes for pivot so that it's surveillance data that would inform the work of this commission and other boards and agencies in the state. And so I know you guys have been giving some thought to that, and the public health informatics upgrades that are needed to also help make that happen. So thank you for joining us today.
Dr. Packham?
Yes.
Bobette Bond, for the record, I want to thank the state for the presentation today, and I want to really amplify what you just said, but also what Commissioner Bonahan said about the public health funding. I think what Nevada has long done like miracles with very little resources, and they're forever figuring out ways to patch everything together that's essential. And then something like this shows, like you said, shows the cracks. But also, I think it would be helpful as a commission to understand the specificity of what's needed. I think that there's, it would be great if there's been a snapshot analysis of what you need to strengthen, you know, going forward, what exists, so that we have a better understanding of what's going to be required to make things work better. And so I think the informatics stuff is going to be great to understand better, but there's got to be a major investment in the state to make public health actually work going forward. And even the contact tracing, Julia, as you were talking, I'm thinking, I know you guys do this for sexually transmitted disease, but the incubation period is so long for COVID-19 that it would take, I would never be able to remember what I did 10 days ago if somebody asked me. I just wouldn't even know. So we've got to figure out a way to use technology in the state and invest in the state as a solution long-term. I just wanted to amplify that. I think this is a good group to work on that.
Absolutely. And most of the health division's good ideas are funded by federal dollars, and so heavily reliant on the CDC and other funding sources. But again, thank you for joining us. To continue on our agenda and keep us going, I'm going to let commissioners tell me and Sarah if we need a break, but I will sally forth if not. And believe our next presentation will be from Suzanne Bierman, who's got, is that correct, Sarah?
No. The other presenters are here for questions and answers should the commissioners have any. But that does conclude presentations under this agenda item.
Okay. All right. Thank
Commissioners,
you
do you want to take a moment? If anyone does want a recess, you can utilize the chat box or just raise your hand here and Mr. Chairman can decide to either recess or continue on. Okay, Mr. Chairman, I don't see any request for recess.
Okay, let's continue then.
Okay.
Agenda item 6, I'll have Sarah give a real brief update on collaboration and coordination between the PPC and other state entities in Nevada.
Okay, great. Thank you, Mr. Chairman. Commissioners, as you might remember from our last meeting, this agenda item here is really a standing agenda item that we anticipate having on each meeting as a way to formally update you on some of our collaboration and coordination efforts with other state entities. And I just wanted to let you know that I have reached out to a couple of several entities, really providing them the commission's kind of tentative meeting schedule and to open the dialogue to discuss this commission's duties and responsibilities. Specifically, we have been in communication with the COVID-19 Response, Relief, and Recovery Task Force, the Legislative Committee on Healthcare, and I've also been coordinating with Chair Cancella on her interim study concerning the cost of prescription drugs. The intent is during all of these communications is really to share information, coordinate, and then collaborate while also reducing any duplication of efforts. I'll continue to keep you all updated on these collaborations via phone, email, and if necessary, I'll set up formal presentations to give you a deeper dive into some of these coordinating efforts. Right now, most of the discussion has been about sharing our new request from the governor and letting everyone know that our meeting is taking place today, also with the intent of developing our commission's work plan and establishing some priorities. So following our discussion later in this meeting, your discussion later in this meeting, I will make good on my promise to follow up with each of them to let them know what our next steps are. Also, I will continue to work with our advisory members and specifically Director Whitley and his office. Again, one of the things I wanted to bring up was, today we had an impressive array of experts, and I really want to thank them and say how pleased I am that they were all willing to join us today. Their goals are the same as ours, and that is to make the life of Nevada patients better. And I want you to know that these experts were here not only to answer your questions today, but as an ongoing resource to this commission. Mr. Chair, I'm happy to take any questions if any of the commissioners have any. Otherwise, that concludes my remarks
for
This is Jessica Flood for the comment. So I'm just going to be a stick in the mud probably for this entire process regarding mental health. I think that, we're looking at integrated healthcare and we'd be missing a major opportunity to not work with other mental health organizations throughout the state and just coordinate on that. We now know that it's not just physical and medical care, but also mental health care. And so just putting that on the table, that if we could have that collaboration, even with the Commission on Behavioral Health or the Behavioral Health Policy Boards, it could be a more rich conversation. And I'm saying that not even just on my behalf, but I talk to community members all the time. I have a ton of stakeholders, and they are all seeing a rise in crises. So talking about crisis now and other behavioral health stuff, I'd just like to keep that on the radar.
Absolutely. Thank you so much, Commissioner, for that highlight. I can tell you that prior to this meeting, I have been in communication with the Commission on Behavioral Health. I will follow up. And then if you have any suggestions on other agencies that we could have that open line of communication with, let's discuss that. And then I will be sure to follow up and then work with them to the best that we can.
Thank you.
Okay.
Hi, this is Flo Khan for the record. A question I have is, I know as we were looking at some of our priorities, one of them was network adequacy. And I'm just wondering, do we have any information on the impact that COVID has had on that provider community, particularly when many of them had to close their doors temporarily as the stay-at-home orders were in effect, and how has that impacted those individual practices, and what will that mean for the adequacy?
Sure, thank you for that question. We have Commissioner Richardson as one of our advisory members. I will follow up with her office and see exactly what information we can get to you, circulate back, and we can certainly discuss having that a part of one of our next agenda items. I think that that discussion and establishing that request is better served under the next agenda item. So if you could, amongst each other, decide that that's something that you would like to see brought in front of this commission, I can certainly work on that. Outside of that, Commissioner Khan, I can work with you and work with Commissioner Richardson's office to get some information and to share that.
I was going to just say, hold that thought, because network adequacy issues did not go away. So.
But I will definitely continue to coordinate our efforts with Commissioner Richardson's office as well, and anyone else that makes sense for the discussion of network adequacy.
Babette, did you have a question?
Yes, I think it's the next agenda item as well, though. I think when we think about, it's good that you are, as the chair and the executive director, are able to coordinate with these other entities, but I think it would be good for this whole commission to hear from them as well. So figuring out how to get them in front of us on things that we think are key issues, I think it would be great to spend part of our agenda building that, because I would love to hear what the task force is doing from the task force. Mental health for sure, that'd be great.
Absolutely.
Absolutely. And again, this is really just a kind of a quick update to let you know that we've opened that line of communication. So certainly if there is a request to hear from anyone, specifically, whether it's a task force or chair of some of these other committees, by all means, we will follow up and see if they would be willing to come in and do a full presentation. Absent that, definitely can get some information sharing to this commission for a deeper discussion. But again, I think really it would be helpful for me as you are discussing your priorities and establishing a work plan. Once that is created, that then allows me to share with these other entities, here's our work plan, here's what we have in front of us, and then really taking a deeper dive at that coordinating effort between us.
Other questions or comments for Sarah? Okay, thank you, Sarah.
Yep.
Hearing none, I'd like to continue on with the next agenda item, which is a discussion of our commission priorities and development of a work plan. I'd like to just make a few initial comments, then open it up. As I said in my opening remarks, the issues of access and affordability remain at the heart of what this Patient Protection Commission is all about. With that said, and with the redirection that the governor has given us as the chair of this commission, I feel like the clock is ticking, and that clock is ticking towards essentially a BDR deadline that's now less than 90 days, if my math is correct. With that in mind, and it's again ultimately up for you as commissioners to decide, my preference would be for us to do our work as a full commission and to engage speakers and inside and outside of government to provide testimony to inform the work we do, but that we meet regularly. I'm going to propose that we meet starting Monday, the 22nd, every other week. That's a pretty rapid pace and change from what we had originally planned. But I think that at least calendaring those meetings and staying on task that way will be critical to us developing those policy recommendations for the governor and at least an outline or sketch of bill drafts that we need to have before Labor Day. I also feel strongly, it's my preference, that we hit the pause button on the subcommittees that we established in our last meeting, and we're poised to get rolling in the meeting in March that was canceled. With that said, the three areas that we were going to explore in subcommittee work, healthcare costs and cost drivers, network adequacy, and the need for Medicaid innovation, those haven't gone away. Please don't mistake my feelings on that. In fact, I think they're going to figure into the reset on priorities that are, again, outlined in the letter from the governor. We heard public comment on network adequacy earlier, and it's come up already in our conversations today. And so, again, what we do with those subcommittees, in my view, is defer any subcommittee work till we've gotten those bill drafts and provided some clarification on what our response is to the governor's request. Again, ultimately, it's up for the commission to decide, but I would like to have us focus on those 5 priority areas outlined in the governor's letter. Just a recap: access and affordability of healthcare, particularly vulnerable populations impacted by the current crisis. Second, innovative approaches to providing healthcare, improving access, and protecting workers. 3, as Julia Peak mentioned, the need to improve local, regional, and state public health and coordination. 4th, improve data collection and analysis for evidence-based policymaking. And finally, his request that we re-engage the Commission on Health Workforce Development. One of the things I would like for us to be mindful of as we kick off this discussion is that if we keep, and I intend to keep the next commission meeting date of June 22nd, that's a Monday in a couple of weeks. Sarah and I will need to have an agenda posted a week from tomorrow. So already time is of the essence, and I'd like for the commission to be mindful in that as we reestablish our priorities, set agendas, and then reach out to some of the speakers that I think we've already identified some for upcoming meetings, that we're mindful that of the deadlines needed just for logistical purposes. With that, I'd like to open it up to discussion and get input honestly from everyone on how you'd like to proceed over the course of the summer, including the next meeting date on June 22nd that we have in the calendar.
So this is Dr. Khan for the record. So a couple of things. I agree with the chairman regarding the tabling of the committees, given the changed circumstances. On the priorities of the governor, the number one is accessibility and affordability. The way I look at that is that is tied down to a great extent with the subject that you alluded to, is the network, because access is in a lot of ways tied into the network of various organizations. And under the current circumstances, with the physicians reluctant to see patients in the offices and mostly going to telemedicine, those who could manage to get that electronic system put in place, not everybody was able to do that, especially in the rural areas. The access and then obviously the affordability becomes tied in to the network availability. If the networks are restricted for patient access, then access becomes a challenge in itself. So I think that's to some extent ties up with that.
Comments?
Dr. Packham?
Babette, yes.
Well, I'm concerned about, I don't see in the governor's 5 priorities network, which Dr. Khan just talked about, maybe I'm missing on. And I don't see that reinstating the workforce work group itself is in these. So I might be missing something that that you're saying. So I'd like to make sure I understand exactly what you believe the governor's expectations of us are. These 5 bullets are pretty far flung, and I think that we can focus on whatever the governor wants us to. That's why we're here, and so I feel good about that. But I think these work groups, if they're suspended or paused, I would hope that we can put a plan together that gives us a chance to return to them. I understand you want the bill drafts done, and I understand the urgency of that. I really do. And I think that we should be doing whatever is in the best interests of the state short term. So in lieu of those committees being the funnel for bill drafts, it would be great if you want to work as a whole committee to, I think, get as fast as possible what are the top priorities for resolving the COVID fight that we should be focused on, because I think the letter's too vague, and I think too vague for us to have a work plan. And I think that we have very specific things we've heard today that are talking about how much progress they've made. But we don't have a list of where the gaps are. We don't have a list, and we don't have a sense of where are we failing, what do we have to do to fix existing remaining problems, what resources do we have, and how do we combine those with what we don't have. So I guess if we're going to pause the committees, I'm okay with that. If we're actually going to work on substantive asks of the legislature to help resolve future COVID problems within these governor's priorities, I think we're lacking specificity.
Okay.
I agree with Babette. This is Jessica Flood. I just feel like, a lot of these issues need a deep dive and really would require a lot of conversation. And I just wonder if we could even restart subcommittees to have that deep dive or deeper conversation, because it seems like in these meetings we kind of stay at this surface level.
If somebody was trying to. So give me some direction, folks, because when I read the governor's letter, I do see at least 5 areas where specificity is called on. I also feel like that in almost every one of those areas, mindful of the fact of the priorities again around cost, network adequacy, and Medicaid, that's an opportunity to use those three sets of issues that we identified. That should be the starting point of our conversation. I think we can have our cake and eat it too. I just, again, when we're meeting 3 months from now and putting the polish on 3 bill draft requests, or at least an outline of what those are going to be, I want them to be responsive to that letter that we got from the governor. However general or lacking specificity we think that might be, if it is not responsive to that, I don't want that to happen. So let's figure out how we get to that end in August.
Mr. Chairman, if I can interject for just a moment to talk about the timeline and the BDRs, and again, our responsibilities. This commission does have the ability to request up to 3 bill drafts. Our deadline for that is September 1. However, the whole charge of this commission is to come up with a robust set of recommendations that hopefully are as far reaching as possible, that we need to deliver to the governor and the legislature by the end of this year. And so I think naturally out of that discussion and this deep dive will likely come 3 bill draft requests. However, when you're talking about your work plan, some of the discussions that we've had, you know, you and I have had, and then I've had this conversation with the commissioners, is really focusing on what those recommendations are, and then the BDRs being a product of some of those discussions. But we need to establish kind of a work plan. What are your priorities? If it is in your intent to follow the governor's recent requests and those 5 bullet points, maybe establishing a timeline in which that review process will take place. So for me to help this commission with your work and your next agendas, you know, establishing that priority. If it's the intent of this commission to follow those, look at those 5 bullet points and saying, okay, over the next 5 meetings, we'd like to review X, Y, and Z on this letter. You know, that gives me at least a kind of a guideline as to what you guys would like and who you want to hear from. And then to Commissioner Bond's request to pick back up where this commission left off at the last meeting. If you want to consider doing that after you do a review over the next 5 meetings, that's certainly within your charge and you can do so. But I do think it is important to make sure that we stay focused on the full set of recommendations that are due at the end of this year, the letter, and then knowing we have certain timelines that we need to meet. And one of those timelines is submitting bill draft requests, if that is the intent, to get 3 out there by September 1. And then our full report is due by the end of this year, no later than January 1.
So this is Jessica Flood. In regards to those recommendations, can we start like putting them on the table right now? And then maybe, you know, in future meetings, we look deeper into them.
Yes.
Do you want to create a running list?
Yes.
I could put out 2 right now.
Let's do it, please.
Okay, so number 1, I would say try to develop, like what Julia Peak was saying, deregulate public health in Nevada so that we have public health districts in the rural counties. And number 2 is sustain funding for mental health. I mean, you guys know where I'm at on that.
Mr. Chairman, this is Sean Shaner. Can I say something really quick?
Hi, Sean. Yes.
One thing that I think might be helpful for us is to better understand the inevitable revenue shortfall the state will face, particularly around the social programs and public health. I think that might just help guide some of our decisions. I imagine that whatever we put together will require some sort of funding in some way, shape, or form. I know what I read in the paper and what I hear, but that might be helpful from a presentation standpoint for somebody to share that with us, perhaps at the next meeting on the 22nd.
Okay. So just overall budget and fiscal constraints, yeah.
Particularly around social programs, Medicaid, behavioral health, mental health. in public health, yes.
Mr. Chairman, this is Howard Barron.
Hi, Howard. Go ahead.
I was just going to harken back to our conversation about telehealth. And when I read the, and I would agree with Bobette that the letter from the governor was very far-reaching and did not have a lot of specifics in it for us. But one thing I took from it was the idea that was there something that has happened in this pandemic that maybe brought to light some opportunities for us, and one of those that you and I spoke about last week was telehealth, and I sent you a few ideas of ways that maybe the commission could look into telehealth as an option to provide more far-reaching care to the rural counties that maybe don't have some of the services available, including physical and mental health options. And it might be helpful for this commission to know before we hone in on let's say a BDR for telehealth, what the state currently has on the books in terms of regulations and statute for that allows telehealth, and what opportunities are currently legal and funded and so forth. So that would be maybe a request that I would have is a presentation from someone who can give us a rundown on what telehealth bills have already are on the books and things that we can go expand on from there.
I agree with you. What if we were to put then what we've learned about telehealth on the agenda for next time, but make sure that discussion addresses issues of course access, but also network adequacy and other themes that have been recurrent since we've been meeting earlier this year.
Yeah, that would be great.
This is Dr. Khan. Quick one on the telehealth. Perhaps it would be helpful to have some information on the technological situation in the rural areas of the state for the physicians available there for telehealth purposes and the resources that they have available in those areas particularly.
That we can do.
Dr. Packham? Thank you. I have two related to what's going on with COVID today that will probably fit into what the governor's letter is asking for. I think we should very specifically ask the state, probably DHHS, to tell us what they need to make this virus results, virus testing results, antibody results, eventually vaccine results, vaccine immunity, how to build what they've already got, how to add to that what they would need to be able to do that effectively in the state. Because they've got some pieces done. I mean, WebIZ is working really well for other kinds of vaccination rates. It would be great, and they might have other ideas. It would be great to bring what can you do to feed COVID into the public health system based on what you already have, and then what is the dollars attached to that. So we're not trying to start over. That's one. So the rates and immunity, and this idea of an immunity passport that I've heard about.
And I think, Bobette, not to interrupt you, forgive me. I think in addition to HHS, I think we'd want to have Caleb Cage.
That'd be great. Yeah, that's why I was trying to figure out what the task force is doing. I think those need to like meld together for like, here's how far we got, here's what's left, here's what we need. That would be good. And then similarly for the contact tracing, I'm amazed that the state's doing as well as it is with its contact tracing program when it's completely under-resourced to do it. And there probably needs to be a combination of manpower and this interview process, but also some technology that would move tracing along faster, and the pieces of that I know people are working on. It would be great to bring contract tracing capacity and needs to this group to see what would need to be funded or what could be. Those are my two. And aren't you proud of me that I got off my 3 committees?
Bobette, you're a team player.
I am. Thank you.
And if anyone read the article in the New York Times yesterday, cruise ships on land, the contact tracing requirements of us as a state are ginormous as we think about the economy as well. So other comments? I feel like an agenda is forming. So
Chairman Packham, this is
yes.
Teresa Bohannon for the record. I want us to make sure that we're mindful as we're doing any sort of recommendation that we have the patient as the center of all of our work. And I mean, we're learning that, you know, patients died alone in the hospital. We had a patient here who was 18 years old who died here in Washoe County alone. I think that we really need to hear from patients who are willing to share their stories of what their experiences were and how we can improve upon that. I understand, you know, with an infectious disease that we had to make those choices in hospitals, but if there's anything that we could have done to improve that experience for people, you know, we have a second phase that's going to be upon us any minute. I shared with you the cruise ships on land story from the New York Times. I'd encourage all the commissioners to read it. It's quite interesting to put in perspective what the unique challenge we have with tourism. And with that being said, I would like to hear what that industry can contribute to our work and what accountability they're going to hold for their employees who are at most risk now as we reopen casinos and seeing some of the images emerging from this first weekend. It scares me. It scares me as a parent of an at-risk child who's been just told to just stay at home. And as Ms. Flood has said, that there's mental, there's you know, the behavioral mental components to that of just continuously asking the vulnerable populations of the state to just remain at home. And some people just don't have that opportunity to stay at home. They're being asked to return to work. And so what are we going to do for those vulnerable populations? And I'm interested in how we're going to define those vulnerable populations. I think we saw a little insight into it today from the data presentation of who were the people, at least during this first phase, that were at most risk of passing and, you know, acquiring the infection. But I think going forward, as we talk about opening schools and the complication of opening schools and what that, I'd like to keep those conversations ongoing so that we can think about how all these different pieces are going to fit into a puzzle that we somewhat have to solve. And so maybe even hearing, maybe Caleb would have some insight into this about how schools reopening and kind of what the plans are for that and health and safety aspects of that. So I don't really have any actual requests, but just the general kind of overarching, like, let's think about those most vulnerable patients among us and how we're going to keep them protected going into the fall.
Yeah, and I think the theme of patient centeredness, I would treat like network adequacy. Let's make sure it's at the forefront of any topical conversation we have throughout the summer. Other comments or ideas?
Dr. Packham, can you hear me? This is Yarleni.
Yes. You might get a little closer to your microphone if possible.
Okay. I would also like to know some information on what is making Hispanics, Blacks, and the population more at risk. What's causing them to be getting infected more often and dying more than the rest of the population? If we can get that information from the DHHS.
So I'm having difficulty hearing you, Yarleni, but hopefully I can, I think that I heard more detailed information on vulnerable populations and at-risk populations, which were kind of touched upon in the HHS presentation, but I think was more information.
Yes, information on what's causing this population, Hispanics and Blacks, to be more at risk. Why are they infected more often and dying more than the rest of the population? What making them vulnerable?
What puts them at risk and vulnerable to begin with, I think is, yes. That's actually on Sarah and I's radar screen.
Well, Chairman Packham, this is Teresa Bohannon for the record. I think, you know, just to dovetail off of that, if we can get outside of just COVID from DHS, just any information that we have about comorbidities, because I think that the data has proven that people with chronic conditions are at more risk. I think that probably, that's just my, this is my guess as a trained epidemiologist, that it could be that those particular populations had a higher burden of chronic disease, and there could be some occupational things going on there, but obviously it would be really good to understand from a state level what is our chronic disease burden.
But Dr. Packham, I would add to that before I lose my thought. I think the occupational issue is huge here, because I think that in the main industry that supports at least Southern Nevada is the resort industry. And I'm trying not to be self-interested here, but we have 120,000 lives in the culinary health plan that are tied to that industry, and very concerned about how they get tested, how they get traced, how they stay safe, how they go home and have the ability to stay safe while they get through a quarantine period. And I think we've made it through this crisis to reopen, but I know that this is going to that we're at the very beginning of how the industry can approach this in a way that doesn't make our workforce take risks that increasingly they're not going to be able to take. They're not going to be able to afford to stay home.
Yeah, I agree. We have an opportunity to elevate occupational health through this. So. Other comments or suggestions? Sarah, I'm going to put you on the spot and help me recap a little bit. If I missed anything, I think we probably have enough for a couple of agendas, and I will leave it up to the group, maybe up in a follow-up communication in a day or two. But I heard a need to have some discussion and consideration of developing public health districts, a need for information on budgetary constraints, and particularly as they affect things like Jessica brought up, which is sustained funding for mental health. We were, I think, absolutely hearing that we need to have presentations on telehealth, including reimbursement issues, access, network adequacy, and what might be remaining rural technological barriers to taking advantage of change in telehealth. Also heard an interest in hearing from HHS and Caleb Cage's efforts on how do we improve, sustain, and extend testing and testing capacity, and then kind of the joint issues of contact tracing both what are the human resource elements of that, and maybe probably modest technological investments or requirements that will need to be making testing happen. And then kind of a recurrent theme, the need to be mindful of patient-centeredness in this, network adequacy issues, and that running throughout all of these issues are a need to be mindful of the occupational health issues and threats that are associated with return to work and ramping up. I'm returning to work in an office in which I supervise 15 people, and that's a gargantuan set of issues. I can't imagine what it's like in a casino or the types of businesses that are mainstays of our economy. So did I miss anything?
Your notes certainly align with mine. What I'd like to do is really have a discussion. I know we are limited on our time today, but perhaps we can, at least for me, to get some clarity on an established work plan. That was quite large. I think that we've heard everything from the governor's request in the letter and those 5 bullet points, and then also some of the items that are not directly reflected in the letter, but tend to also align with some of the bullet points. I know during our discussions about developing a work plan, we've talked about kind of taking all of these thoughts and then making it some sort of tangible work plan in such that we have identified some topic areas. And so certainly some of those will fit amongst those topic areas, but for the purposes of creating something for our next several meetings, I know we have, I think, 6, and the next agenda item will discuss the actual dates and the tentative schedule. But to establish the framework of the work of this commission for at least the foreseeable future, I hear that there is a consensus to respond to the governor's request for this commission in the long-term recovery of this pandemic. But going through those 5 bullet points, can I get some clarity at least on what specific topic items you'd like, commissioners, for the next, let's throw it out there, 5 meetings? We are on a tight time frame, so if it's our intent to hold 6 meetings between now and the end of August 31st, that's in advance of our first deadline to submit BDR requests, then it would be helpful to at least have those topic areas. So I've heard the specific requests and have that, but can we get a consensus on what we'd like to start for our next several meetings? That would be helpful, and I think it sounds like the commissioners are also wanting that as well.
So Jessica, this is Jessica Flood for the record. I just heard Dr. Falcon just give a list of topic areas, right? I wonder if on the agenda, we could have standing agenda items that would be ideas for BDRs that fall under those topics that we just discussed. We could have additional topics to focus on, and then a standing item for that list of recommendations for the governor. And so every meeting, we could touch on that, and people can suggest, here's something that we might want to put on the list, just so we have a running list and we're not starting from scratch.
Yes.
Yeah.
Great.
Great idea.
This is Flocon. Can I make a recommendation? First and foremost, and I think Sean brought this up, the budget is going to be critical to anything that we do, and understanding what funding is going to be available, both for public programs, but certainly resources that we're going to need to address, and how what we're going to be looking at overall. I think we need to have that. And then perhaps go into, as we do these more often meetings on the Mondays, that we just take one topic at a time and really focus on it. So I think, telehealth being one that there's already a lot of information, and that goes to the point about network adequacy, and really based on kind of what's happened under COVID and what we can at least perceive in the near future of how we're going to have to operate. Looking at just that, and then as Jessica said, maybe bring some proposals with respect to how we want to address that within that topic area, and then focus on that and then go to a different one. I think trying to take too many things in each of these meetings is going to be challenging.
Yeah,
and so at least for the next two, do budget and then do telehealth at the next one, and then we can focus on some of the others that we maybe testing capacity as another one, and contract tracing as part of that, and data collection as part of that, but just getting them really focused and targeted at each meeting.
Right. You know, thank you. That's exactly what I was alluding to, is that it would be helpful, you know, building these agendas and getting these data requests and these presenters. In an ideal world, it's something that we could get relatively quickly, but in all reality, these take time. So having a consensus of where you guys would like for a topic area. I heard a lot, and we can certainly get started, but I think that it would be helpful to have identified topics and then kind of following that for each meeting, so we can prepare accordingly for each one of those discussions, instead of having you know, questions out there that are, you know, it's a way for organizing. So I guess my ask is just if I could get some clarity on what those identified topic areas you would like for, you know, the next 5 meetings, that would be helpful. Certainly, of course, I really do appreciate Commissioner Flood's suggestion about having standing items on there, and I think that that's a great idea. I just think for formality purposes and for organization purposes, it would be good to identify some topic areas for the next several meetings.
Well, let me propose maybe a middle ground here, Sarah, because I think we have identified several issues.
Yep.
And what I'd like to propose is that we develop maybe a draft agenda that incorporates what we will focus on the next meeting. I think folks are content to discuss and hear telehealth. I think there's probably more consensus around that issue than others, but also think that putting together a draft agenda that we share with the commissioners for feedback on, that includes standing agenda items, includes running lists of things that we have discussed, in some cases now 3 times as a commission, that we don't want to forget, but I think it might be a tall order to think 5 agendas down the road. I'm primarily concerned about June 22nd and the one that we have calendared shortly after that. But I think we can accomplish the task at hand for Sarah and I, which is to get an agenda in shape for June 22nd, but keeping other items that every one of you have brought up today kind of on our radar screen.
This is Jessica Flood, and I just want to say I agree with the other commissioners on the budget, and I believe that the budget status is coming out later this week, so that would be timely. But in talking about the budget, I also want to note that I think advocacy is part of this commission's role. So, you know, sometimes you could be pragmatic and go, oh, there's no funding, but really it's like, how do we really, you know, support these causes that generally don't get that much advocacy? I just heard the other day that a senator said she gets hundreds of emails about education and 0 emails about social services and public health. So, you know, if we're really focused on enhancing public health, what does that look like despite the lack of funding that we're surely going to see?
Well, and let's not let lack of funding, I agree with you completely in that imagine if local health districts had the budget for 10 contract tracers before this all started versus what they actually had. I mean, I heard stories about people being repurposed within health districts so they could go from 2 contract tracers to 5. And that's pennies on the dollar for what we're now paying to crawl out of this. And even if we're operating under budget constraints, we can still hear from people about whether we want to be, you know, penny wise and a pound foolish in the future. So that's fair game.
Dr. Pagam, can I just clarify for your and Sarah's notes that what I was saying about what is needed to build the backbone of ongoing testing, I really meant testing to immunity to vaccine. I mean, that whole that trail so that we see how to plan for that and what the options are. Because we're
Thank
not
you.
going to be okay till we can do that.
Okay.
And commissioners, certainly if you have any thoughts after this that you would like to talk about for our next agenda, please reach out, send me your requests for standing items. I know that if it's the intent to call a meeting to order on the 22nd, we do have a short time frame in which we need to establish an agenda. So any additional thoughts or requests on standing items, send it my way. And then I will get a draft agenda out to this commission for further feedback as soon as possible.
I will commit to getting a draft of that out by the end of the week and work with Sarah to make sure that that's in your email by Friday. That'll give us a weekend and a little bit of time to make sure that we're faithful to a lot of information that's come up in today's conversation, and keep the ball rolling with an eye to not just the June 22nd agenda, but the ones following that.
Can I just ask a clarifying question? Because I think we made progress here. It seems like between the governor's letter and the original charge of the Patient Protection Commission, what we should be providing and thinking about is a list. I know we have to work together on agenda building, but a list of what would be going into a BDR, and then what would be going on this long list of recommendations that the PPC is charged to provide.
Yes.
Kind of per Commissioner Flood's thinking about trying to keep that work going so it's consolidated. Okay. And they might be random and they might be emails to Sarah, and that's okay. Okay.
Yeah, and if we could just review that every meeting, like if we're all emailing Sarah, just like, hey, this is what we've got. Like, I'm just going to run down the list, and then we can all be thinking in our heads, like, we need to make it more specific or not.
And don't be shy. If there's something that you thought should have been on the list and it's not, please tell us.
Yes, I know that some of my emails might get annoying from time to time where I'm asking for, requesting agenda items. But by all means, I really, really appreciate the feedback. And it does not bother me if I get, 10 ideas from you or 10 suggestions in 10 separate emails, or I get one really robust email. I encourage you to reach out, and it really helps me so I can organize this and make sure that you guys have exactly what you need going forward as you're continuing on this review process. So please don't be shy.
Okay, I'm trying to be mindful of the time here. If it's all right with everyone, I'd like to we've kind of bled into agenda item 8. I'd like to close agenda item 7. I think we have enough information to proceed. Wanted to bring up the issue of the proposed meeting dates that Sarah shared with you a week or so ago, all on Mondays, June 22nd, July 6th, July 20th, August 3rd, August 17th, August 31st. I'm not necessarily saying that we will end up needing all of those meeting times, but I'd like to have them blocked out. We have a couple of clinicians that need to calendar patients out a couple of months, and everyone is busy. So my hope was that these would be agreeable, and for most of us far enough out that we could block times on Monday. I'm thinking my personal preference is no more than 3 or 4 hours, but if we started by 9 o'clock on each of those Mondays, we could aim to have our business completed by lunchtime, with maybe possibly going over, depending on the topic and what we have on the agenda. Any thoughts or comments?
This is Howard Barron for the record. It's fine with me. Those dates are fine.
Howard will strangle me if we don't agree on dates.
Yeah, I have no problem. I think we just need to, each one of us obviously has to make adjustments because of the seriousness of the situation and the time crunch that we are dealing with. So I'm fine with that, whatever it takes.
Okay. Well, if that's okay, I'd like to maybe entertain a motion to approve those meeting dates, and we will calendar those.
Dr. Khan, so moved.
Thank you. Do I have a second?
Aaron, second.
All right. All in favor of putting those 6 dates in the calendar, say aye.
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 Any opposed?
I have a comment, Dr. Khan.
Yes, sir.
Mr. Chairman,
Yes.
if I may.
Yes.
I think we have discussed all the challenges, issues, etc. I think I would be remiss if I don't comment on and commend really the governor, his team, and all the stakeholders in the state. The way the whole state came through this and coming through now with the cooperation of every stakeholder and the leadership that we have noticed from the governor's office down, we have really crossed a major benchmark without major crises, as we have seen in some of the other states. So I think it's appropriate for us to appreciate that we have been collectively very successful in moving forward. A lot of work still needs to be done, obviously, but I think with the same effort and consensus building, despite adversity and other challenges, we would come through.
I concur. Leadership matters. Any other comments? Okay. I think I'm prepared now to move on to our second public comment. Sarah, do we have anyone in the queue?
So let me first turn to Leslie and ask her if we had received any testimony via email. New testimony. I'm sorry, hold on, Leslie.
Sorry about that. No, we have not received anything new.
Okay, great. Mr. Chairman, it looks like we have 35 attendees. I've got one request to speak, and let's give a moment to everyone else. If you, all the attendees on the line, if you would like to speak at this moment, please raise your hand. I will start again with Ms. Vivian Leal.
Vivian Leal, for the record, thank you again for the opportunity to speak. Even as we isolate, vulnerable populations continue to be burdened by the very diseases that place us at high risk. One of the benefits of improved telehealth has been that many chronic illness patients have been able to maintain continuity of care requirements, such as prescriptions, treatments, therapies through telehealth. And these have been considered adequate for pre-authorizations so people can continue on their current treatment plan if it is being effective. This has been done through Medicaid and Medicare waivers for reimbursement, all under emergency provisions. But this should be required of all plans selling insurance in Nevada. Personally, I was moved off my dosing schedule by an entire month through a pre-authorization process pre-pandemic, which, if you can imagine, on a person who really is vulnerable, having hardly any B cells, heavily impacted my physical and mental health. And I was unable to go to the only center who would provide a test that would give me enough information to appeal, because it was only available at an MS center to which I could not physically get to. I tried everything in Reno and Sacramento. So just saying that as an illustration of how hard it gets when you're just trying to stay the same in the midst of the pandemic. So we should retain this benefit that a lot of patients have had through telehealth through the pandemic. But even for the long-term health and cost reductions, frankly, for our state. Thank you.
Thank you.
Okay, Mr. Chair, it looks like we don't have any other public comment. And so that concludes the second public comment.
Okay. Do I need a motion to adjourn, or can I just summarily adjourn this meeting?
You've exhausted your agenda. You don't need a motion.
I don't need a motion. Well, I appreciate everybody's time and contributions. I feel like this was an extremely productive meeting. Sarah and I, as promised, will get out a draft agenda with probably some comments and asks of commissioners, but feel like that I have a much greater sense of direction where we're going over the course of the summer, and appreciate everybody's efforts. I've got a Zoom meeting number 299 in a few minutes, so I'm going to move on. And if hearing no other objections, I believe we're adjourned for the day.
Thank you.
Thank you. Thanks, everyone.
Bye, everyone. Thank you.
Thank you.
Thank you.
Bye. Stay safe, everyone.
Thanks.
Thank you.